Welcome everyone. Can you hear me? Just give me a thumbs up or something in the chat. Good. Okay, fantastic. I think we'll make a start. A few of you are still trickling through, but we've got a good number here, which is excellent. So before starting, I recognize a fair few familiar names, but some of you might not know who I am. So my name is Shoaib. I'm one of the course organizers for BitePACES, and we're holding many free webinars over the course of the next couple of months, and we've held a bunch over the last kind of over the last diet. And it's been so nice seeing a lot of you come back to these webinars, and I hope they've been useful. And as always, before we crack on, I'm just going to talk a little bit about the course. We've had our recent courses in September and October, which were pretty much sold out and very successful. We have a 1-day course and a 4-day course, and we're shaping up to hold those next January and February. So if anyone is interested, please do head over to the website. The QR code's on the top right there. And any questions you have, you can message me anytime. Join our WhatsApp group. That's where we post all about our free webinar series. But yeah, in terms of our courses, we really do pride ourselves in having small groups of no more than 2 of you. We kind of cover all the stations. So yeah, please do check that out. And for those of you that are attending, you can get a discount through using this discount code. Some nice feedback that we've received. I won't kind of labor this too much, but we've got almost 5 stars on Google. And here's our webinar series. So Vishnu is going to be leading a clinical consultation webinar today. And then on Saturday, we have another one of our faculty members doing a cardiology webinar. So again, we're holding a bunch of webinars throughout the next couple of weeks. You can find those on our website or on our WhatsApp group. So please do join the group. And please do check out our PACES course. And without further ado, I'm going to hand over to Vishnu, who's a diabetes and endocrine registrar. He's done a few webinars for us now, and they've been very popular, which is why I've asked him to do another one, because I released a poll on the WhatsApp group, and a large number of you said that clinical consultations is something that you'd like help with. So I will hand over to Vishnu, and if you have any questions, just pop them in the chat, or you can always ask them in our WhatsApp group after. So yeah, I will hand over to you, Vishnu.
Perfect. Thanks so much, Shoaib, for the introduction. So let me just share my screen. As was said, I'm very happy for you to ask me any questions throughout. I'll keep an eye on the chat. The way this consultation will work, or session will work, is I hope you can see my slides. Could someone just say that they can on the chat? They
Yeah,
can see.
you can see them. The only
Perfect,
thing,
Shoaib.
I don't know if this is intentional, but it's like your screen's like your background.
Oh,
Do you see what I mean?
um, okay, I can see that.
That's
Let's
fine if that's the way you want it, but I'm just to make you aware. That's what I think.
okay. Let's do that. Let's change that up. Okay. Hopefully I'm no longer in the background.
So it's still, I think it's fine to be honest. Like it's just like, yeah,
Okay,
it's absolutely fine.
perfect. Okay, so the way we're going to run this webinar is that um we're going to just talk about the PACES exam again, for those of you new to the by PACES. And we're going to go through 3 clinical consultations. I really need some volunteers because it'd be so dull for me to just talk through the clinical consultations. I just want people to have a go, just in the limits of whatever webinar can do, because I know we can't physically examine. And I'll just give you some feedback whilst you go through those clinical consultations, and so bring out some key learning points. All the consults today are based on real patients. However, they're also based on real cases. So 2 of them have been real PACES cases in the last 2 or 3 years. Uh, One of them been in the last 5 years. So all of them have been PACES cases. Okay, so because we want to get into the good stuff, I'm going to keep on showing this carousel every single time I do a webinar, because I think it's really important just to get into your mind what the PACES looks like. So this is just taken straight from the website. And the things that we're focused on, the two stations we're focused on, is station 5 and station 2. This is how you are marked. So you're marked by station, but you're also marked by skills. Okay. So it's a bit like a driving test. You have to pass all the stations, but you also have to pass each skill. Okay. So if you get too many minors in inverted commas, then overall you'll get a major and you won't pass the exam, even though you have enough marks to pass. It's just dependent on the stations. So it's quite common for people to not get enough marks in identifying physical signs. Okay, so too many borderlines and unsatisfactories that can just bring you down in paces. So you have a situation where you have to pass each of these clinical skills as well as overall. Hope that sort of makes sense. Why is consultation important? Well, all of those skills which we were talked about is assessed in consultation. Okay, so all of the other encounters or stations, they obviously don't focus on all of the aspects. So these are where all the marks you can come from. Okay, so consultations are big jackpot pots of marks. This is again from the website. I've literally just copied and pasted it. And why have I done that? Is because I want you to just change perspective a tiny bit. And there's a move, I think, from some of the candidates who've sat paces more recently to have a few more acute presentations. Okay, because remember the goal of the exam is to try and get a consultant to be confident in that you're going to be a medical reg, they can manage to take and manage patients appropriately. So instead of sort of chronic conditions, there are a few more acute presentations. Okay. And so we're going to have a mixture of those sort of cases. Usually there'll be a referral letter, probably a bit more detail than I have in my presentation, from either the GP or the A&E, UTC, etc. And you get it 5 minutes before, and you have a chance to prepare for your station. And then you have 20 minutes for the station, 15 minutes for history taken, exam, and a discussion with a patient, and then a 5-minute viva, effectively, with the examiner who's leading that station. Any questions so far? Happy with that format? Okay, good. My suggestion is to just split it into threes. Okay, so look, the 5 minutes at the end is fixed. So the 15 minutes, I would just split it into three. Okay, so take a focused history based on the referral. So ask your key questions, because that's going to determine which exams you're going to do. You never have to do a full examination of a system unless you think it's really relevant and really important to do a full examination of a system. So there's no scenario where you have to do a full cranial nerve examination. Okay, so that's not what clinical consultation is about. You can cherry pick what you want. Again, you also never have to do a full respiratory exam, starting from the hands, going all around. But if you think that's going to be helpful, then you can do it. So there's a clinical judgment aspect here, and you've got to choose what you need to do to help you make the diagnosis and also screen for associated conditions. Okay, so we'll talk about that. And you've got to allow yourself 5 minutes back to go back to the patient to discuss their concerns and explain your next steps and management plan. Okay, so the patient's always going to ask you, what are you going to do next, doctor? Now, what's next? Okay, so I like to just split it into thirds because it's easier to remember. There's obviously flexibility, and you can use your 15 minutes however you choose to, but you need to just bear in mind examination does take longer. Okay, especially when you're trying to work out what you're trying to examine. It's not laid out for you like in the neurology station. You have to do a full, I don't know, a lower limb neurological exam. That's obviously laid out for you, so you know exactly what to do. Whereas here you are cherry picking, so it does take a bit longer to come to that decision. So try and get that focus history out of the way, and just the more time you have to examine, you can always come back and take the history. So there's never a situation where you can't go backwards. Okay, so my point is to try and get an examination done sooner rather than later, because you may be missing signs. And the other beautiful thing about the clinical consultation is that you can take a history whilst you examine. Okay, so you can carry on asking questions when you're looking at someone's hands. Key tips for any clinical consultation. So I've done a previous webinar on clinical consultation, so I've tried to just keep the similar sort of message. Just remember where you are in the hospital. Are you in the emergency department? Are you in the outpatient setting? Are you in ambulatory care? I should say outpatient review. Think about where you need to go, where this patient needs to go. Do they need to be admitted to a hospital ward? Can they be sent to outpatients? Can they come back to ambulatory care? It also helps you focus on the investigation. So you don't start ordering something ridiculous. So you don't say, oh yeah, let's get an urgent MRI, but let's send the patient home. It doesn't quite make sense. Okay. So you've got to have rationale to what you say. Pick up on any cues the surrogate patient gives you. So the surrogate patient actually has 2 or 3 pages worth of information that they can tell you. Okay. And they will sometimes drop something down when you take the history. So pick up on it. And please do make sure you leave enough time to address the patient's concerns. Okay, that's a really key holistic point in this consultation. I'm going to pause there because I was keen to start getting into the consultations themselves. Has anyone got any questions on how clinical consultations work, how to approach them? And I'm going to ask for a volunteer to go through the first case with me. So I'm going to pretend to be the patient, and you're going to, unfortunately, can't examine me because it's virtual, but you can take the history and you'll be vived, and we'll talk through the station. Perfect. Fintan has volunteered. Give me a second, Fintan. I'm going to allow you the ability to speak when I find you. Okay.
Hello. Thanks very much.
Perfect. I'm going to take that as no questions. If there are any questions, just put it in the chat. If not, we'll carry on. Okay. So this is your referral, okay, from the GP. I'll just read it out. So, dear doctor, thank you for agreeing to see this 37-year-old lady, Sarah Jane, with a persistent headache. She describes a generalized headache for 3 months. Those are her investigations and her observations. I'm going to give you a couple of minutes. So the way this webinar will work, is that you will have 10 minutes to take a history and explain to the patient, okay? Because the 5 minutes you don't need because you're not examining me. But I will tell you, if you want to, any examination findings, I'll tell you exactly what those are.
Okay. Thanks very much. That's great.
Perfect. So I'm going to give you a couple of minutes to compose and think about what you're going to ask. In the exam, you will have 5 minutes. Okay, so you have 5 minutes to work out what questions you want to ask. But here, I'm going to give you just 2 minutes. And whenever you're ready, I'll start timing you.
Thanks very much.
Vishnou, just a quick one. Shoaib here. I think I don't know what it is. It's like your head is obscuring part of the slides. I don't know if it's like that for you, Fintan.
I can see okay. Like I can see the slide there that we're on with no problem.
Maybe it's just me. Okay, forget it. Don't worry.
Okay. You probably can't see anything now, can you?
No, I can't see the slides at all.
Sorry for interrupting. I probably just messed everything up.
Let's see if that works.
Still can't see the slides at the moment.
Yeah, let's have a look. Can you see the slides now?
Yeah, I can see it there perfectly.
My head's not in the way, is it?
No. Well out of the way now.
Good. That's a bizarre situation I've not had. All right, that's enough distraction. I think that's time for you to start.
Yeah, good to go.
Perfect. Go for it.
Hello, Sarah Jane. Thanks for coming in. My name's Fintan. I'm one of the doctors on the ward. How can I help you today?
Call me Sarah. And I've had this headache for the last 3 months now, so it's just getting worse, and I'm not and GP gave me some paracetamol, and some ibuprofen. That's not helping at all. It's just, I don't know, I'm getting really sick of it.
And would you be okay to tell me a wee bit more about the headache?
Yeah, sure. I mean, it's just all over. Like I said, it's been getting worse. It's just been, I don't know, it's lasting longer. It just hurts more, and it actually stops me doing work.
Okay, so the headache, when it came on, did it come on suddenly or gradually?
Gradually.
And is it there all the time, or does it come and go?
It's there all the time, I'd say, but I think it's worse at certain parts of the time of the day.
What time of day do you notice it to be worse at?
Probably, I don't know, maybe in the morning. I sometimes wake up with a headache. It sometimes wakes me up at times. Um, Maybe at night. Yeah.
And how would you describe the nature of the headache?
What do you mean?
As in, is it like a sharp headache or a dull headache?
I wouldn't say it's sharp. It's probably, I guess, dull then.
Cheers. And does it ever move anywhere else, or does it always
Uh,
just stay both sides of the head, or does it ever move?
Yeah, so I don't think it's one side of the head. I think it's both sides.
Mhm.
And what? Sorry, you said does it move anywhere? No, I don't think it
Yeah.
moves anywhere.
And any other symptoms that you've noticed went apart from the headache over the last 3 months?
Um, I know not over the last 3 months. No,
Particularly any vomiting in the morning or
no, I've
anything?
not. I felt I've have been feeling nauseous, but I haven't
Mhm.
vomited. Um, yeah, it's just really frustrating, I guess.
And is there anything that makes the headache worse that you've noticed?
Um, Not really. No, I'm not sure.
And anything that makes it better?
Paracetamol initially made it better.
Mhm.
Then ibuprofen. Now I got to codeine. And then there's cocodamol, which is apparently paracetamol and codeine together. Um, so they all initially work a bit better,
Mhm.
but then it wears off.
And how often are you taking pain relief at the moment?
Um, 4 times a day, the cocodamol now.
I see. And in terms of your health in the past, do you have any underlying health problems? Any medical conditions or operations or anything?
So no operations. So I have been going to the GP because I'm 37 and I'm trying for a baby. But um, so he's been sort of doing um some test earlier. Uh, but so because it's been going for 6 months now.
Mhm.
We've only really been trying for about 8 to 9 months, but for 6 months my periods have been sort of hit and miss. Um, and I guess I didn't really go to the GP earlier enough, but and then the headache came along, and then I think that took precedence for me at least.
I see. And just to check, any change in your vision that you've noticed?
No changes in my vision that I've noticed. No,
Any sort of weight changes? Have you put on any weight or lost weight?
I probably have put on a tiny bit of weight, not significant, but a tiny bit. Yeah.
And any issues with your libido or anything like that?
Yeah. I mean, well, I guess with the headache, I don't have. It's sort of hard to, yeah, try for a baby. Yeah,
Mhm.
because if you're just head hurts all the time.
And any sort of easy bruising or anything like that that you've noticed?
No, none of that.
And is the headache worse if you lean forwards?
Uh, Maybe if I bend down but not lean forward. No.
Mhm.
You have
And
five.
any,
You have 5 minutes left.
cheers. So, and just to check then, are you taking any medications apart from the cocodamol at the moment?
No, no other medications.
And are you allergic to anything?
No,
And do you smoke at all at the moment?
never smoked.
And do you drink any alcohol?
Just occasionally, maybe. I mean, not been drinking that much for the last couple of months, to be fair, but maybe once a week, twice a week.
Cheers. And what do you work as at the moment?
I'm a lawyer.
And how's work going? Any problems at work or
No, not really. I think it's been the same.
cheers? So I'll just do an examination if that's okay. So
What
I
would you examine?
I look fundoscopy, looking for any evidence of papilledema,
No papilledema on endoscopy. Anything else?
examine eye movements and visual fields.
Yep. And they noticed a bitemporal hemianopia.
Cheers. I would look to see if there's any evidence of cushingoid appearance, any um sort of central obesity, any easy bruising, any abdominal striae?
None to all of them.
Cheers. And then I would look to see if there's any features of growth hormone overdose, such as a large tongue, protruding jaw, or large hands.
None. No to all of them.
So I'd also examine her blood pressure now, which I think we have, which is normal.
Yep, that's her blood pressure.
Cheers. And then just a quick test of her cranial nerves as well, just to check the face, that there's no asymmetry of the power in the face.
Apart from the eye movements, which we've talked about, and sorry, the visual fields we talked about, the cranial nerve is unremarkable. Examination is unremarkable.
Thanks. So I'd explain to her now what's going on. So thanks very much for letting me examine you, Sarah. What we found today suggests that you will need some further investigations. What could be causing these symptoms is a very small tumor in the brain, which we will need to do some more tests to try and find out exactly what's going on.
You think I have a brain tumor?
It's a possibility at the moment as a reason for this symptom that you're having. But there could be other causes, but I think that we need to look into this much further and try and find out what's going on.
Can it be cured if it's a brain tumor?
In all likelihood, it can be, but we would only be able to tell that for certain once we've got more investigations. What I think is a possibility is you've got a small tumor on a gland inside the brain, and that could be causing this visual field defect that we've noted.
Okay.
And do you have any questions or concerns I can answer for you at the moment?
What's the treatment, and can I be cured from this?
The treatment for this is possibly going to be surgery or medications, but we can only know that once we've done a scan of your brain and taken some blood samples.
Is this the reason why I can't get pregnant?
It certainly could be that if this, what we think could be a tumor, it could be producing hormones that are preventing you to become pregnant at the moment. So hopefully once this has been treated, you would be able to become pregnant afterwards.
And you said that there's medications. What sort of medications? Are there any side effects of them?
From my understanding, I think the medications would have some side effects, but I would need to double check the information to be able to tell you exactly what they are. But we'd have a much better understanding of the plan once we've got your bloods taken and we've got an MRI scan of your head. And we'll also get in contact with the endocrinology team who give us more advice. And if the scan does show a tumor, we'll be speaking to the neurosurgeons as well. But I'll keep you updated with sort of the results of your investigations and the further management.
Okay. It's the end of your 10 minutes. So you're going to get Vivid now. So what's your differential diagnosis here?
So I think it could be pituitary macroadenoma would be my main differential diagnosis for this. Other possible diagnosis could be a pituitary adenoma, but unlikely given that there are no other findings on physical examination apart from the bitemporal hemianopia.
So when you say, sorry, what's the difference between a pituitary macroadenoma and a pituitary adenoma?
I mean that she could have a functioning adenoma or a non-functioning adenoma.
Okay. Is there any other functioning adenoma that she could have that you have not screened for?
So I've thought about the Cushing's and the growth hormone. I'm just trying to think about any other ones.
Okay.
So I'm afraid I can't think of it at the moment.
No problem. What investigations would you order? You've listed a few of them.
So I'd request for an MRI of her head. Also, would be checking bloods for pituitary function. So that would include LH, FSH, her prolactin level, cortisol, and an IGF-1. And I can't think of any others. That maybe her thyroid profile to see the TSH level.
Let's say a prolactin level comes back at 8,000. What do you think her diagnosis here is now?
It'd be prolactinoma. Yeah, that was.
What treatment options would you consider?
So I'd consider referring her for transsphenoidal, or rather, I think that you can try medical options first. So I think that dopamine agonists would be an option. So that would be carbergoline or bromocriptine. And then if those treatments didn't work, I think the next option would be transsphenoidal resection of the macroadenoma.
You mentioned carbergoline. Are there any risks or side effects associated with carbergoline?
I'm not certain, to be honest. I don't know if there would be any sort of movement disorder associated with it, but I'm honestly not sure. Just I was thinking if it's dopamine agonist, but I'm not certain, to be honest.
Perfect. Endoviva.
That was.
I'm going to leave the what's the chance of cure because that was, I think, a bit mean. Okay, so the chat's going through. So someone's a prolactinoma. Yes, that was a diagnosis here. Lung fibrosis. We'll go through the answers in a second of the Viva, but please do carry on putting in the chat if you've got any questions at all. So I'm just going to try and summarize case. Sorry, I got the age wrong because I changed it in the last second because I wanted a bit more pressure on the pregnancy. So it's a 37-year-old lady with persistent pressure style headache over the last 3 months. I think you picked that up and you characterized it quite well. Irregular periods of the last 6 months, sexually active, not on contraception, I was trying to conceive. You didn't specifically ask me about lactation, which is why I never gave it to you, because that would have made it obvious, which is why I held back on it. Otherwise, fit and well. Social history, as we talked about. I don't think we got to family history, if I'm not mistaken.
Yeah, I missed that.
It's quite, you can see how 5 minutes, especially with a headache history, can be quite tough at times, right?
Yeah, there's a lot to get through for the headache.
So let's talk about the Viva answers and stuff. Okay, so I think you just order every single test. You test every axis when it's pituitary profile. And the way I try and remember it is so ACTH, cortisol, TSH, T4, LH-FSH, and sex binding globulin, and then your estrogen, progesterone, plus or minus testosterone if it's a man, and obviously your prolactin. Okay, so just order all of them. Is the rule. Because what we're saying here is that this person's got, so even if they've got a non-functioning pituitary tumor, that might affect the rest of the pituitary axis. Okay, so they might be deficient in cortisol or thyroid, etc. So they may need replacement. Okay, so it's not all about what it's producing, it's about what the effect is on the other hormones.
Cheers.
Treatment options. You got the one I told you the prolactin level was high. I think it was quite tricky to know it was definitely a prolactinoma. So don't beat yourself up on that. The one thing I will say is a prolactinoma is the most common type of a functioning pituitary adenoma. Okay.
I see. I think I was a bit more focused on Cushing's and the acromegaly.
So the Cushing's. So this is a real life tip. So may not and patients in PACES are real life patients. So Cushing's does not tend to have visual field defect. And the reason why is because people with Cushing's, they get very symptomatic very early on because the cortisol, as soon as it rises, they get all the signs straight away. Okay. And people don't like weight gain. People don't like easy bruising, etc., etc. Okay. They don't like that. Whereas prolactinoma, especially in men, presents later. Okay. Because the first symptom in men is reduced libido. They don't really get the lactation. Okay, so they get headache and reduced libido. Right. So you can see how men would delay their presentation until they start losing their vision peripherally. Okay, so they're men with walking around with huge pituitary tumors who don't know about it. The second thing, the way the visual field defect happens, most people won't recognize they have a visual field defect, okay, until very late on. So that's why people may not know they've got a visual field loss. So if someone says, "Oh, I sometimes bump into things," that means they're a bit further along the line, okay? So Cushing's is less likely based on the fact that they have a bitemporal hemianopia, but you can't rule anything about this out. That's why you test all the hormones, right? Acromegaly, you're going to have really solid features, okay? Again, you're going to present relatively early. So what I would say is it could be a pituitary tumor. You have no idea. You say it's probably likely to be a macroadenoma. And when you say macroadenoma, you mean more than 10 millimeters because it's present on the optic chiasm.
Yeah. And so less than that, unlikely to cause any visual field defect.
Sorry, say that again.
If it's less than 10 millimeters, it's unlikely to cause any.
No, it just depends on where it is. It just depends on where it is. But yeah, but it is less likely. It's not unlikely, it's less likely.
Oh, cheers.
You're always going to send them for formal visual field testing. So that's another investigation you're going to order. You're going to send to a full, visual field testing and vector potentials. And you're also going to do other things in preparation for surgery, for example, and their liver function test and a chest X-ray. What treatment options? Well, you got them, they're dopamine agonists or surgery, TSS, or radiotherapy. Now, this is the reason why I brought this case, because I thought prolactin is something that's not well known about. It is actually relatively more, it's far more common than acromegaly, okay? Why chest X-ray? Good. So cabergoline, coming on to side effects of cabergoline now. So cabergoline, the most common side effects, when you explain to a patient, when you start them on cabergoline, you tell them they're going to feel a bit, they can feel a bit dizzy, a bit nauseous, etc. Okay, that's like with every drug. But actually there's a reason for here because there's dopamine agonists. It can drop your blood pressure, it can give you a postural drop. Some rarer side effects, bromocriptine more than cabergoline, to be honest, can give you pulmonary fibrosis. Okay, so the ergo sort of class of dopamine agonist is linked with pulmonary fibrosis. So you just want to know what a baseline is to make sure it's completely clear beforehand. Okay, and it can give you valve damage as well. Again, that's actually super rare. The thing is actually a bit more common now that we realize it. So in the literature, it'll always say, so I've copied this, the literature will always say, so this is what the my local trust says what we're meant to say, but actually in the literature, and the literature says it's rare, but what you need to warn people that are started on cabergoline is they become impulsive. Okay, it's a really interesting phenomena. So they want to do, so you've got people that start gambling, they bet their house on things and they lose their house because of the drug, or they ruin their relationship because they get into illicit affairs, etc., and they have no insight to it. So it's as if they've developed a psychiatric condition because of being on this drug. And the rule I tell people is you need to tell someone, one person at work that you trust, and usually a partner, that you're on this medication, and that sometimes they just need to be aware of these changes that can happen. It's unlikely to happen, but it can happen. So, for example, there are some people that start spending money on first-class tickets, plane tickets. Okay, it seems like just a little nice treat, but it's money they didn't have to do something they shouldn't do. Okay, so yeah, so that's the reason why I highlighted it. It's just because it's quite an interesting sort of side effect. I hope that was sort of clear. So it's a bit more insidious as a side effect, and quite an interesting side effect for a drug, I'd say. So I didn't ask you this question because we moved on, but what is the chance of cure? Pretty high. Prolactinomas respond really, really well to medication, actually. Okay. It's always going to be dependent on tumor size, and classification, and invasion. So if it invades the cavernous sinus or around the carotid artery, the tablet's probably not going to do it. The other thing that you're really worried about is if the tumor's been there for such a long time, it can get stuck to the bone. And when you start the medication, the tumor shrinks and it peels away the bone away. So you have a CSF leak. Okay. So you've got to be a bit careful with that. So you have to keep in that in mind. So you sometimes have to keep patients in hospital and start the medication.
Thanks very much.
Has anyone got any other questions in that case? Sorry, it was a bit of a left field case, but I, as an endocrine reg, I couldn't do a clinical consultation webinar without an endocrine case. And I thought I'd go with something a bit left field rather than the classic acromegaly cushions. Any preference for her as planning pregnancy? So yeah, so that's a really good point. So to be honest with you, we're gonna have to tell her to hold off pregnancy. Well, she can't become pregnant because she's almost got a natural contraceptive in prolactin. Okay, so we need her to completely treat her, get that tumor down. Depends on an MRI scan. So it doesn't mean it could be cabergoline or it could be TSS. The reason why we would want to avoid TSS is actually harder to become pregnant when you've had a pituitary taken out. Okay, so we'd rather just try to treat her with medications and shrink the tumor down. The problem is if she becomes pregnant right now, let's say by a miracle her prolactin halves and she becomes pregnant, pregnancy increases the size of your pituitary gland, right? So you're at higher risk of pituitary apoplexy, where your pituitary sort of bleeds because of the blood supply. So that's the thing we need to avoid. So we need to shrink the tumor down. So it'll depend on the tumor size, etc. But tablets is normally the first line, and whilst there's a pressure to try and get her pregnant, or help her get pregnant. Sorry, we have to just wait till the tumor shrinks, okay? Because the tumor size matters. There's a few questions. Okay, so sorry, could you repeat why they need to be in hospital? So then the hospital one was a specific point. It was about if, for example, the tumor is so big and it's actually stuck to the walls and gone into the bone or things like that. Once you start cabergoline, the tumor shrinks, but when it shrinks, it sort of pulls inwards. So it can pull like the structures around it inwards as well with it. So you can get tears and things like that. And if it starts pulling away bone, you have CSF leaks, and you have to be in hospital to monitor a CSF leak. So that's like a sort of rare example, but prolactinomas tend to be quite big. So that's the reason why. Okay, what else? That's why you need to. How long are you kept on cabergoline? So it depends on your tumor size. Okay, so cabergoline can be used in two different ways. It can be used to treat as cure. So small tumors, you can cure it. Okay, and you can stop after. So there's no specific time. It's not like Graves' disease where you give 18 months of carbimazole. Okay, this is dependent on what it is, or it's used as a bridge to surgery. Okay, so in this case we probably are heading towards surgery because she's got visual field defects already. Okay, so we're going to give her the cabergoline. If it's small enough, like if it's like a small macro, we can probably give the cabergoline, and it will shrink the tumor enough for vision to completely recover, and then we can carry on and just see if it shrinks further. Or we use it as a bridge, so it shrinks a bit more to make the surgery a bit easier. Do a TSS, and then she'd be cured from a prolactinoma perspective. Please, can you repeat all differential diagnosis in this case? So look, the differential diagnosis here could be any pituitary tumor. Okay, so the bitemporal hemianopia focuses your mind that it could be a pituitary tumor that's a non-function, Cushing's, acromegaly, and in this case, prolactin. You can also have a craniopharyngioma, but it will depend on the bitemporal hemianopia. And I think that's it with the questions. Any other questions? Fintan, thank you so much for volunteering. That's really helpful.
Thanks very much for giving me the case. I found that very good.
We're going to move on for the interest of time. Who wants to volunteer for the second one? Sarah has volunteered. Sarah, give me a sec. I'm gonna have to try and find you in the chat. Oh, how do I? Okay, so there's a Q&A. Sorry, there's people writing in the chat and there's people Q&A. I'm gonna answer this one right now, actually. So, how do I reassure a patient in an exam if I do not know the answer to prognosis? I do not want to mislead the patient. So look, so if the patient's asking you're absolutely right in saying, look, I'm not sure, but I'll speak to the specialist here, which the endocrinologist, the doctor who deals with us all the time. I'll come back to you. So that's definitely the right answer. Okay, so if you don't know the answer, you can't lie. Okay, so that's definitely the way to approach it. Now in the Viva, you have to offer your opinion. Okay, so you have to commit to an answer. Okay, and I think you should know that most pituitary tumors have good prognosis. Okay, because they're benign tumors. So pituitary carcinoma is a super rare diagnosis. Hope that helps. Okay, Sarah, I'm going to find you one thing. Okay. So similar setup. I'm going to give you 10 minutes, 5 minutes to do the history, and plus you can ask me what the examination will be, and then go back to the patient for 5 minutes. So 10 minutes in total, and then we'll have a bit of a viva, and we'll go through the case like we just did now.
Okay, thank you.
Referral from UTC, 28-year-old man, Joseph Okaro, with chest pain and breathlessness. He's got a background of sickle cell disease, but he's not known to this area. Those are his investigations. I'm going to give you a minute to just digest them, and then you're allowed to shoot.
Okay.
I'm just getting the timer. So let me know when you're ready.
Okay.
Perfect. Time starts now. Whenever you're ready, Sarah.
Okay, yes. Hi, I can start now?
Yeah, start.
Hi, my name is Dr. Mahmoud. I'm one of the doctors here in the clinic. Am I talking? I didn't check the name.
It's Joseph.
Hi, Joseph. Can I confirm your age?
Yeah, I'm 28.
Yes. How I can help you today?
I'm in a lot of pain.
I'm really sorry about that. You want me to give you any painkiller now?
Yes, please.
Okay. So, do you have allergy to any medication?
No.
Okay, so I will give you some medication now. And are you able to talk now?
Yeah, I mean, I'm still in pain, but okay. Just ask me questions.
Okay, so I just want to ask you, I can see that you are coming with the chest pain and shortness of breath. Is that right?
Yeah.
And when this started?
I mean, it started maybe 2 days ago, but it got worse yesterday, and I couldn't cope with it at home, so I had to come in.
You did the right thing by coming here. I just want to ask you some questions, and then I will examine you and I address all your concern. So you have this chest pain for 2 days, and this progressive, you're saying, right?
Yeah.
And have you noticed anything precipitating this chest pain? Any trauma?
No trauma.
Any heart racing?
Any what? Heart racing?
Yeah.
No.
No. Okay. And this shortness of breath also started 2 days ago?
No, that was more recently. That probably pushed me to come into hospital. Yeah.
Yes. So and shortness of breath, you are feeling it all the time, or you are doing only some exercise? It's at rest, or when you are doing any...
Well, I'm in too much pain to exercise. I've got pain everywhere, so I'm not moving.
Okay.
So.
And do you have any pain in other joint in your body?
Yeah, sort of my back, my hips, and my legs.
And any recent history of fever?
I think I felt a bit hot at home, but nothing recently. I don't know. I mean, I think they checked my temperature when I came into hospital.
Yes, and it was normal, I see, right?
Yeah.
Okay. So, and I can see, and have you noticed any change in your color of your skin?
No.
Any bleeding from any part in your body?
No.
Any recent history of travel?
No.
Any recent history of infection or flu symptom?
No.
Okay. So, I can see from your history that you have a sickle cell anemia, right?
That's right.
Yeah. Do you have any other medical condition apart from sickle cell anemia?
No. No, just sickle cell.
Are you taking any regular medication?
Just I mean, I take painkillers when I'm in pain, but nothing else.
No. So, I will, and any family history of note?
Sickle cell.
Sickle cell.
Runs in the family, yeah.
And do you smoke?
No.
And what about alcohol?
I don't drink.
And what do you do for a living?
I don't work.
So you are on work. And how is this condition affecting you? The sickle cell?
It's pretty bad, yeah. I mean, it flares up quite often, and yeah, it's a real burden. It's one of the reasons why I can't work.
Ah, I'm really sorry about that. So I would like to examine you, and while examining you, I might ask you some question. Is that okay with you?
Okay.
So I see that he's vitally stable, right?
Yeah, you've got his these are his observations. So you tell me what your thoughts are.
Yes. Okay. His oxygen is low. Okay. So I would like to examine his chest for any crepitation,
Okay. Anything else that you'd like to do?
and also I need to check the heart, scope the heart for any murmurs.
There's no murmurs. Anything else?
Check the GVP,
It's not elevated.
not elevated. Any lower limb edema,
No.
and any character of the pulse.
Any character?
Yes, in the pulse.
No.
Regular.
Yeah, sorry, it's regular. Sorry, yeah.
Okay.
Regular, good volume.
Yes, and he was complaining about joint pain, so I need to examine his back.
Yeah, there's no his back is tender.
Hmm.
What else are you looking for?
It's tender. Any redness or inflammation, any redness or hotness.
No redness, no hardness, no difference in temperature.
No difference temperature. Okay. So what is your main concern, Mr. Joseph?
And sorry, the last thing was your breath sounds were reduced at the base with the occasional crackle.
Okay, so he has some crackles. Okay, we reduced sound. Okay.
Can you stop the pain?
So now I will, no, I will also, the patient oxygen is very low, so I would like to give him oxygen.
Okay.
And also I would like to do AABG for him.
Okay. So you're still with the patient?
Yeah. So, because your oxygen is low, so I will give you some oxygen. Okay. And, so Mr. Joseph, I think that as you might have a crisis from the sickle cell that you have.
Okay.
Do you know about this condition?
Yeah, I do. I told you I have it.
Okay. So that's why I need to admit you in the hospital, and I gave you oxygen. So we'll monitor you, and we'll give you a strong painkiller.
Why is my oxygen level low?
Yes, I think you have this condition that's affecting your lung now. So you might have you have this crisis that causes occlusion in the blood channels in your lungs. That's why you have this chest pain and breathlessness. So I would like to give you oxygen, and I'd like to give you strong analgesic.
What are you going to give me for pain? Because it still hurts.
I will give you morphine, and we check your breathing.
Okay. And is there anything we can try to stop crisis in the future?
Yes, so for a crisis, I think I think we can give we can check. I think also I need to check for the spleen. We can make splenectomy for the future.
So you think if you wait, sorry, do you think if you take my spleen out, that'd be a good?
I'm not quite sure. He might have a sequestration crisis. That's what I'm thinking.
Okay. So remember, you're talking to the patient still.
Yeah. Okay.
So do you think taking my spleen out will help then?
No, no, no. For with the patient, I'm thinking that I'm talking with them. Okay, no, I'm thinking we'll give you oxygen. I'm not quite. And I will discuss it with the consultant and come back to you regarding the treatment.
Okay. I get end the station there. Sorry, I know there's a bit of confusion with examiner and patient.
Yes.
So I'm now examiner, definitely. What's your management plan for the patient?
So I think this patient has a sickle cell crisis. So the main treatment option is analgesic and symptomatic treatment. So this patient is desaturated. We'll give him oxygen. I'm not quite sure about other treatments for the sickle cell crisis.
Okay. Anything else? So you're going to give him.
Yes, I will do for him investigation. I need to do for him chest X-ray, and he might need this high resolution CT scan. We need to do an echo.
Why would you do a high resolution CT scan for this gentleman?
Because he has a crepitation, but I'm not quite sure. He might have acute respiratory distress syndrome. But
What's your diagnosis for this man?
It is it's I think pulmonary occlusive crisis. I'm not quite sure of the name. Forget it.
What is the long-term treatment for this patient? What options do we have?
Not steroid. No. Okay. No,
Okay.
I couldn't remember.
I'm gonna end the Viva there.
Okay.
Thank you so much. Honestly, this webinar does not work if people do not volunteer. Okay, it's so helpful. Again, this is a slightly niche area. I don't know if Sarah, if you see many patients with sickle cell in where you work. So sickle cell is sort of something. If some places you see lots of patients, if there's a center, some places you never do. So what this patient has is an acute chest crisis or a chest syndrome. So something called ACS, but not the ACS that the cardiac ACS. It's ACS, acute chest syndrome. Okay. Let's talk through the Viva things first.
Okay.
So the gold standard answer is to say pain relief as per their individualized pain protocol. Okay, so across the country, lots of hematology units have set up a pain protocol for that patient. So some patients are because these patients have come in hospital all the time with a vasoocclusive crisis, which doesn't involve the chest, a simple, uncomplicated vasoocclusive crisis. They obviously get used to pain relief, so they may not need more pain analgesia to try and manage their pain. So that's why that pain protocol is really important. So you're just going to use whatever their pain protocol is, okay? But it's going to involve an opioid, okay? So let's be clear, it's going to involve morphine as a stat dose or fentanyl, lozenge, whatever. Depending on where you work, it's going to be slightly different protocols. I would give this patient oxygen. So sometimes I would also give patients with a normal oxygen saturation a tiny bit of oxygen if it helps their pain, okay? Because you're trying to prevent a situation where they go from a vasoocclusive crisis, which is sickling of their blood cells, to a chest crisis, okay? Because you're trying to stop that next step. ABG, I think, is important. Group and save and a cross match with the view to transfuse, okay? This guy's HB was 67. So a top-up transfusion will just help improve oxygen delivery. Incentive spirometry is what I had there on the right-hand side, okay? So incentive spirometry is actually a really good tool. It really does help with sort of chest, with analgesia, good analgesia and some chest physio, especially if they're starting to get close to a chest crisis. Core hematology, okay? IV fluids, yes, if you definitely get cannula, that's a good point. PCA morphine, so it depends on what their protocol is. So you have to try and avoid getting them onto a PCA, but in this case, we're probably heading towards a PCA sooner rather than later. But this is where you would use the phrase, look, I'm going to get specialist hematology inputs, get the hematologist involved, because we may need to think about specialist interventions such as a PCA and exchange transfusion. So that's what I was looking for. So a chest crisis is pretty much it's very high mortality, okay? When you have a proper chest crisis. Sorry, does anyone know how you define a chest crisis? Can everyone hear me? Sarah, can you hear me? Can you hear me, Sarah?
Yes, I'm hearing you. Yes.
Perfect. Sorry, just someone on the chat said no voice for me. Okay, cool. So look, the simple answer is chest X-ray with something on it. Okay, so patients with sickle cell don't really have. Okay, they technically do have chest infections, but that chest infection with no low oxygen saturation is a chest crisis by definition. Okay,
Okay.
so it could be infiltrates, consolidation, it could be anything on the X-ray. But if they're hypoxic, just with their SATs being low, that is a chest crisis. So it doesn't need to be any specific pattern. The traditional pattern or the more likely pattern would be bilateral sort of infiltrate changes. So someone's put that in the chat, I think. Yeah. So that's the usual thing. So that's what a chest crisis is, okay? And it's normally someone that's had a vaso-occlusive crisis that's carried on developing because they've either delayed coming to hospital, delayed presentation, and they've gone into a full chest crisis. I want to just talk about how I approach a sickle cell patient and taking a history. So I would try and encourage you to use it like a asthma patient. The reason why I say that is because they're both chronic conditions and you're going to ask really similar questions. So you're going to ask, okay, have you had an asthma attack like this before? So you're going to say, well, look, you've had a crisis before. Is this similar to a crisis? Is it the same parts of your body that are hurting now that normally hurt before? So is the pain similar to a previous crisis? So you can judge on the scale of, is this worse or better? How you've asked about how long it's been ongoing. You just need to ask what sort of analgesics did they try at home. Now the key questions which I've not written down here, and I was hoping someone would tell me. So just think about the asthma history. There are key questions that you ask in a patient with asthma that you have to ask for the patient with sickle cell. Amazing, Zainab, excellent. So ICU admission, okay? Exactly the same as asthma. So I would ask, look, have you ever had a chest crisis before? When was it? Have you ever been admitted to ITU? Okay, so you're trying to work out what they do. The next thing you go is, so what treatments have you had in the past? Have you ever been on hydroxycarbamide or hydroxyurea? Have you ever had exchange transfusions before? Okay, so you have to try and take a really detailed, focused sickle cell history almost. Okay. You can ask about neurology as well, because obviously there's a higher risk of stroke. Now, what are your differentials here?
Pulmonary embolism.
Yeah, so exactly. So I just think you could have asked about travel. You did ask about travel, to be fair, but you could have asked about sort of risk factors for it, and also more risk factors for PE, because you can't scan every single patient with sickle cell disease that's presented with low SATs and chest pain. You can't do that, okay, because it's a lot of radiation. Would it be useful to ask? Yes, it would be useful to ask the last heme follow-up status, and yes, you do need to check about vaccination. So these are the extra sort of gold points. So if you have time, then you can ask about vaccination and long-term management. When we get to the Viva, we could have talked about make sure they have flu. What other sort of vaccines are we in particular worried about? You mentioned a splenectomy. This patient didn't have one, but you mentioned it. What would they have?
Pneumococcal vaccine.
Yeah, pneumococcal. So you're encapsulated bacteria.
Yes.
Okay.
Penicillin. You should have penicillin G as per long term.
Yeah, absolutely. That's right. And the last thing I was going to say is, just make it a big deal of, I need to say, you said that they're going to have to be admitted to the hospital. I think when you should tell the patient that you're going to speak to the hematologist, or at least be clear about this, and you're going to ask them, for their specialist input. When you speak to the examiner, the idea is actually we need to get hematology on the phone now. Okay, we need to know. We need them to be involved as soon as possible, because an exchange transfusion takes a long time to get set up. You need a VAS cath or things like that. Anim, that's a really good question, actually. I don't know the answer to what the prophylaxis would be if it's they're allergic to penicillin V. I'll come back to you. I'll see what my local guideline is, but I'm not entirely sure, if I'm being honest. Any questions on that case?
No, thank you. That's a difficult case, but thank you to give me this opportunity.
Yeah, no, all the cases today have been difficult. They're slightly left field because you guys can obviously do the more standard ones. So
Yes.
I thought I'll give you the weirder ones instead.
Thank you so much. Really helpful.
I need another volunteer. Anyone want to volunteer for the last case? I had two at the same time. Although I'm on my browser, will that be difficult for you to see it? I might just go with Risa. Okay, let's have a look. It's basically whoever see put the hand up on the thing. I'm gonna go with that one. Right.
Hey.
Perfect. I think we know the drill by now. So 5 minutes, 5 minutes. And you've got a referral from UTC, the dreaded UTC. It's a 45-year-old man with a fever. We'll call him John for this purpose. It's classic UTC. Can't be asked to put his name down. And those are his investigations and observations. I'm going to give you a couple of minutes to collect your thoughts, and then we'll go straight in. I'm just going to get my timer ready. Let me know if you're ready.
Yeah, sure.
Okay. Time starts now.
Okay. Hi, John. My name is Dr. Tal. I'm one of the doctors in UTC today. I understand that you've come in with a temperature. Is that right?
That's right.
Okay. Do you mind telling me a bit more about what's been going on?
So yeah, so look, I've had a bit of I've not been feeling great for the last 2 months maybe, and I'm getting all these temperatures, all these fevers, and I went to the GP a couple of weeks ago, and he gave me some antibiotics, and I'll be honest, I didn't even take many tablets. I didn't feel well enough anyway, and I don't know. I just decided to come into the hospital.
Okay. So it's a few months you've not been feeling quite yourself.
No, I've not been well at all. No.
Okay. And were there any changes that happened a few months ago that you can think of?
Not really. I can't. No.
Okay. Fine. Have you been away recently?
No, I haven't traveled. I've not left this country at all.
Okay, fine. And just a bit more about what's making you feel unwell. How do you mean? Is it pain or tiredness?
Yeah, I guess just tired, just fatigued, just I don't know. I don't know. It's like having a flu, but like I know 10 times worse.
Okay.
I just don't feel any energy. Don't out of breath all the time. Just yeah.
Okay. And would you say things have been getting worse over the last few months?
Yeah, I don't. Yeah, it definitely is getting worse. I don't think. I think I needed to come to hospital today because it's not just a fever. It's just everything's been getting worse.
No, absolutely. Yeah, you did the right thing, and hopefully we can get to the bottom of things today. So I just wanted to ask you a few more questions. Noticing a headache at all?
Sorry, say that again.
I said, have you been noticing a headache?
No headache. No,
Okay. Any changes to your vision?
no change to my vision.
Any sort of nausea or vomiting?
I do feel nauseous, no vomiting.
Okay, fine. And you mentioned that you've been breathless.
Yeah,
Has that been getting worse?
probably. Yeah.
Okay. And would you say, have you noticed that you've got a cough?
I do a bit of a cough, but
Okay.
nothing coming out.
Okay. Have you brought up any blood with your cough?
No,
Okay. So you're not producing any sputum?
no, I'm not
Okay.
reducing.
Any pain in your chest?
Yeah, a bit, actually. Yeah,
Okay. Whereabouts is that?
just right in the center. It's not always there. It's just, when I move.
Okay, fine. Is it worse when you breathe in?
Yeah, it is actually. Yeah.
Okay, fine. And have you noticed any pain in your tummy?
No, no real pain in my tummy, I don't think.
Okay. Any pain in your joints or your muscles?
I've got muscle aches all over, but no
Yeah.
pain in my
Okay.
joints. No,
Okay. Fine. And any changes to your bowels?
no, not really.
Okay. And what about your urine? Passing urine okay?
Yeah, it's okay.
Any have you noticed any blood in your urine?
No,
Okay. And have you been going more often or less often?
probably less often. I'm not drinking as much water anymore.
Okay. Okay. Fine. All right. And just a bit more about your general self. Have you noticed any weight loss in the last few months?
I probably have been losing a bit of weight. Yeah.
Okay. How much would you say, if you know?
I don't know. I just know I've lost a bit of weight.
Okay,
People say
sure.
that I look thinner.
Okay. Has anyone around you been unwell?
No, not really. No.
Okay, fine. Um, and just a bit more about yourself. Do you have any health?
Health problems. So
Yeah.
I've got asthma slash COPD. I don't know if they've worked out which one I have. Uh, but I do smoke, so maybe it's the COPD. And I have high blood pressure. And what else? Those are the main ones, really.
Okay, sure. And do you take any regular medication?
Um, if I can't remember, I take the inhaler. And I'm on some tablets, but I'll be honest, I don't really take them.
Okay, sure. Fair enough. And you said you smoke at all? How much do you smoke in a day, would you say?
It still depends on things, doesn't it? So sometimes they go up, uh, maybe 30 a day. Sometimes it's just 10 a day. Just depends, what else I'm doing.
Okay, fine. And do you drink any alcohol?
Yeah, I do. Just a couple of cans a day.
Okay. And any recreational drugs?
Yeah, I mean, I've obviously cut down a bit because I've not been feeling well, but I have used in the past. Yeah.
What was that? Sorry, do you mind telling me which drugs?
Yeah, so it's just a bit of, sometimes I have a bit of cocaine, but sometimes cannabis, it just depends on, what's available.
Um, sorry, you cut out on the last bit that you said. You said a bit of cocaine and cannabis and
Just depends on what's available.
sure, okay. Any IV drug use?
IV, are you
No.
asking, have I
Like
injected myself?
injected, yeah.
I have, yeah, I mean, I don't do it very often, but I have, yeah. When my
Sure.
friend brings some stuff over, so
Okay, and when was the last time you did that?
it would have been months ago, not recent.
Okay, fine. All right. Um, now I'm just going to examine you if that's okay.
Okay.
Um, John. So
Yep.
fine, so I'll just be looking at him and I'll have a look at his hands to begin with, looking for splinter hemorrhages, just generally any nail changes. Then I will look at um I'll listen to his chest, like rest wise, um, then I'll have a listen to the heart, mostly listening for any murmurs. Have a feel of his pulse. See, I think his obs were fine, apart from the fever. And then I'll probably have a feel of the cervical lymph nodes and have a look at the legs. Yeah, I think that's okay. Fine. Let me just move this 1 sec.
Let me know when you're ready to carry on. You've got 2 minutes to go back to the patient.
Okay. Okay. So thank you for speaking to me today, John. It's been very helpful to hear things from your side. Okay, thanks. So I think that you mentioned you've been unwell for the last few months, and I think the reason is that you may well have an infection, and that infection is possibly on one of the valves in your heart. So
Okay.
what this means is, and this can very commonly take a long time for to present itself. I'm just going to ignore that. And what I think is important is that we keep you in hospital. What we'll need to do is some blood tests and a scan of your heart to see whether that is the case. And we will start you on some antibiotics, and that will be to treat the infection. How
Okay.
does that sound? How do you feel about that?
I mean, it sounds quite serious. Could I die from this?
It is serious, but you're in the right place. And um, sometimes patients, the way we treat the valves with the antibiotics, things can get better. But if not, we might have to consider surgery. So there are definitely options that we have. Obviously, I appreciate that that would be a concern about, this being extremely serious that you could die from. I have it's always a small possibility, but we do know that we have good treatments that can work, and if worse comes to worse and they don't work, we can always consider surgery.
Okay. You've run out of time. Well,
Okay.
artificially ran out of time.
Yeah.
Perfect. Thank you. Let's get on to the Viva.
Okay.
Oh, hold on. So you've already outlined your management plan, but what other sort of specialist bits of the management plan will you do?
Fine. So at the bedside, the important things to do would be an ECG. Here, the most important things, I think, given that my primary differential is infective endocarditis, I'd be looking at the ECG to check the PR interval. That would make me concerned for an aortic root abscess. Secondly, I would want to do a urine dip looking for proteinuria. Well, we've done that. I would send off the urine for microscopy, looking for any casts, etc. Then I would also want to do fundoscopy at this stage to look for any retinal complications of septic emboli. Further on, I would like to take some blood tests. Importantly, I'll need three sets of blood cultures, ideally taken at slightly different time intervals. And I'd like to do the routine blood tests to check for, we've already got the inflammatory markers, etc. So I will.
What criteria are you looking for?
So I'm looking to fulfill the Duke's criteria, I
Okay.
believe.
What
Yeah.
is the management? So what's the treatment for this patient? How do we cure this patient adequately for his infective endocarditis?
So this patient will need long-term IV antibiotics. So that would be dependent on the sensitivities that we get back from our cultures, and that would be how we would treat in the first instance if he did indeed have an abscess, or if he continued to get worse despite antibiotic therapy, then we may have to consider valvular replacement.
Yeah, okay. How long will the antibiotics be? You said long term. How
Yeah.
long?
So probably I think around 4 to 6 weeks.
Okay. I'm going to end the Viva there. Cool.
Cool.
Well done. So modified Dukes, yep, that's right. You said that. So this is a summary of the case. So this is a man with a previous IVG drug use, signs consistent with peritonitis. The the issue is, so you know the 5 minutes that you would have spent. I know you didn't have 5 minutes, but you know the 5 minutes you would have spent outside the room preparing for persistent fever. Gosh, what could it be? It's a bit dangerous in this one because you could really go down a, oh, is this malaria, right? And aren't think of those questions, TB, cancer. There's loads of reasons for persistent fever. Even an untreated infection could be a persistent fever. So I thought you did quite well in just keeping an open mind and just moved to what was important. On the right hand side is the ESC guidelines from 2023 on what you do for infective endocarditis, and just sort of the sort of algorithm post the initial bits. The other things I would say is think about, so he's an IV drug user, right? So I would think about the other stuff that you need to test for, because just because he's got, so the satisfaction of search, just because he's got infective endocarditis, he might also have HIV and Hep B. So think about those ones as well. So we need to test for all of the bloodborne viruses now.
Okay.
I've said will need. So you're right. He probably is not definite. I think IV drug users, just the nature and his presentation, so you might have fluid overload, etc. He's probably heading towards a situation where he needs a valve replacement. Because what bug is he likely to have?
Maybe Staph aureus.
Yeah, so Staph aureus is far more aggressive as a pathogen, as a bug, basically, on the valve. So he's more likely to have more destruction, rather than the usual stuff. But what would we do? So there's one thing you didn't say in the Viva bit, which we would do normally. So who would he be referred to?
Cardiology.
Yeah, in particular.
In particular, not sure what you mean, sorry.
Anyone else in the chat? Intervention. Yeah, so intervention only with the after you think about the valve. So intervention is for angio, so cardiothoracic. Sorry, you're right. TOE, yeah, I'm looking for the people that decide. Yeah, so it depends on where you are. But most people have an endocarditis MDT. So it's a regional thing usually. So you refer to the local effective endocarditis MDT. So you need to be referred to them, and they have a look at the valve, and then they can discuss the micro sensitivities, etc., and they can determine treatment. Okay, because if they know what the sensitivities are of the, if it's Staph aureus, let's say, then they can tell you how long to treat it for. You can think about PICC lines, and you can think about, does this man need surgery, and you do interval echoes over that period of time. Another thing, again, you don't need to necessarily do this in the clinical consultation, but just to consider, because you may get asked about it, is what are we going to do with this man? Well, initially we're going to admit him because the first couple of weeks of treatment is, it's quite crucial. But if he's stopped his IV drug use, because he's at high risk, if we sent him home with a PICC line, maybe he's just going to inject himself with more heroin at home, right? So we need to do that risk assessment. But theoretically, he could be OPATted 4 weeks, 3 weeks or 4 weeks potentially. Okay, so those are just sort of things to think about. So the one thing I wanted you to say was endocarditis MDT, and then they can help you determine treatment. Would you mind going through a quick summary of those statistics at the bottom of the algorithm? Yeah, so look, so if we in the algorithm, so if you have a patient with suspected, so remember, at the moment we're looking at, so these are patients that have a persistent fever, so we're not entirely sure. I'm trying to hunt a fever down. Okay, so the places that you hunt fevers are your heart, your brain, and your bones. Okay, so those are the places that you hunt fevers. So the algorithm says, so you do a TTE. The TTE almost always, I'm sure you've all realized, says can't rule out infective endocarditis in normal scans. So you have to progress to TOE. And then you go talk through the criteria. So definite is easy, possible, you carry on just to repeat the cultures. And let's go down all the way. Okay, so the algorithm. So a CTA. So if you have a inconclusive TOE, and a paravalvular things, you can get some imaging for it. So CTA, for example, anyone familiar with the cardiac CTA? Just gonna see if there's any cardiologists, budding cardiologists. If not, I'll carry on. So cardiac CTA just basically lights up, and it will give you a good overview of the anatomy of the valve. If you've got extra cardiac complications, that's for septic emboli. So I think someone put it in the chat. The septic emboli, so the PET CT will just hunt those down. Okay, so if you've got widespread disease or emboli all across the body, so that's very useful. So for example, a stroke or something like that, or an abscess elsewhere, I mean, you should be able to get it with a whole body imaging rather than a PET CT. But that's why you would do those sort of things, okay? Because as soon as it's affected the heart, it can embolize pretty quickly. And the reason why, if you don't have any symptoms of extracardiac things and you have no idea, so this is class 2B, so this is not something that they recommend. It's got relatively lower evidence, but they would still suggest that consider. So this is a consider advice from the ESC guidelines, whole body imaging, just because what if it has spread? Okay. So I would suggest that you would only say in the exam, we'll screen, we may consider whole body imaging or targeted imaging if we're suspecting septic emboli. So if there's extra cardiac complications, whether it's, I don't know, severe liver pain, hepatic pain and inflection, stroke, things like that, or bowel ischemia, so you might want to just think about this. I hope that sort of answers. So that's a summary of the bottom things. I wouldn't worry too much about it. What I was really quite keen is the middle bit of the algorithm from the European Society of Cardiology guidelines. Any other questions on infective endocarditis? And do you need a TOE of the eye? No, absolutely not. So if the TTE confirms an infective endocarditis, you don't need to go down a TOE. It's just that TTE as standard transthoracic echo very rarely confirms it. Okay. Now, the side point to that is if you wanted to plan surgery, you might want a TOE anyway to get better views. Okay, so that's a slightly different scenario. But you can also do a CT TAVI, CT TAVI protocol. There's other ways of getting an image of your valve. Okay. But initially, if you've got a TTE which shows significant valve dysfunction, and you've got the other bits of the Duke's criteria, that's infective endocarditis. It's really bad infective endocarditis because if the TTE can pick it up, then it's more likely to be advanced. Any other questions at all?
I was just gonna ask more of I just wondered whether you would use the words infective endocarditis with the patient.
Yeah, so that's a good point. Yeah, so I would say I don't think you were jargony. I think you said infection of the heart valve. I think you can, if you say, so let's say you accidentally say, I think you have a condition called infective endocarditis, and what that means is you've got an infection of one of the valves in your heart. I think that's okay. So I think if you explain it straight away, I think it's fine. But you also don't have to use it just because it's a very medical jargony sort of term. Just like, for example, in the first case, I wouldn't use the word prolactinoma with a patient. I think Fintan actually explained it quite well. It's a tumor that might be secreting a hormone. He didn't say prolactin time, but because he wasn't sure about it. But yeah, I think explaining it rather than saying it out loud is always better. But if you did say it, then just explain it straight away and it'd be fine.
Cool,
I hope that helps.
Yeah.
Any other questions? I'm just wary of the chat. Sorry. Okay. I'm going to move on. So I don't know if some of you may have been in the last webinars that we've done on clinical consultations. This time I've tried to shift it a tiny bit to more acute ones just to give you a bit of variety, because I think the books and everything else will have the old style of clinical consultations, which was very much, oh, look, here's a very rare condition, etc. But I think there is a move to try and get you to, here's a medical reg referral. What do you think? What would you do? How would you manage this? Practice is key. This is the most similar thing to real life. Okay, so this is the thing that you actually do on a daily basis in your medical jobs. And all I would just say is remember to use the time wisely when preparing. Okay, so think about the systems that you need to examine. Think about which parts of the examination you're going to do, and think about what are the key unlocking questions. Okay, so we didn't do a TIA station today, but for example, a TIA station, you know that you must talk about driving at some point. Okay, so if that comes into your head as a diagnosis, you just write down DVLA in your notes and make sure that you mention it. I'm going to leave this slide up, and I'm just going to check the guidelines for that antibiotic. But if there's any other questions at all, please do ask. Can I ask, does HIV still need explicit separate consent? Do you know? So I do not. I do not have separate consent for HIV. Okay, I tell patients, look, we also have to test for other bloodborne viruses. I do not think it's to worry about. And also, sorry, just a side note. So there's a national program. Is it national? No, sorry, it's a London-centric program. Sorry, it's a London-centric program where every single patient that comes to A&E gets tested for HIV and Hep B. And it's an opt-out situation, so it's not an opt-in. Hope that helps. So I wouldn't make it a big deal. I'd just say, look, we're going to test for other bloodborne viruses. HIV, as you know, as a new diagnosis, is a classic communication station, by the way. Do we counsel for drug use referral? Yes, that's a good point. So later, I mean, I think it's that is part of the long-term management, to be fair, and I sort of skipped over it. But I guess the long-term, sorry, the most pressing matter was to try and get the infective enteritis sorted out. I think so. My local, yeah. So I think there's a move about the HIV thing. Just a general question: would you recommend doing PACES early in IMT1? So look, that's a difficult question to answer. I'd say it depends on how much practice you're able to get. So the key thing about timing when you do PACES is choosing a job where you can get the hours to practice, going around the wards in your local hospital, pick up signs of patients with someone. So I think that's the most important thing. So it's not necessarily where you are in your training. Early in IMT1, most people wouldn't tend to do that. They would tend to do it at the end of IMT1 at the earliest. But if, for example, you've had a lot of experience, you're on a job that helps you carry on practicing, I think it's purely based on circumstances. So for me, the most important thing is not where you are in your training. It's about, are you in a job where you can consistently take time, I know, after lunch in the afternoon to go around the wards and examine patients, or after work. Because if you're finishing late all the time, or really hard rota pattern, that might be quite tricky. So I hope that helps as an answer. In prolactin melanoma case with bitemporal hemianopia, do we need to mention about DVLA? Need to stop driving if she is? Yeah. Okay. So yes. So what she needs is formal visual fields. Okay. So bitemporal hemianopia means that she's got restricted visual fields at the sides. Okay. So it depends on how extensive it is, but we should advise her to stop driving anyway. But we need the formal visual fields to be done as soon as possible. So yeah, that's a good point. Any other questions whilst I look at the guidelines for the sickle cell prophylaxis? Just loading up. Any other questions at all? It's erythromycin. Sorry, I forgot who asked me that. There is erythromycin as an alternative in BART, so I think it would be universal, to be fair, because penicillin is universal. I should have guessed that, to be honest, but I wasn't 100% certain. Okay. Any other questions at all about PACES in general, about clinical consultations? Best resource for revising for clinical consultation cases. Yeah, so that's a really good one. Question. So I actually found what's the book called? So there's a book that comes in three volumes. It's like I think it's I think it might be called an aid to PACES, which I used. And I thought that had quite good brief clinical consultations. The problem, Robin, is now that the exam is different. Okay, so there's only been, what's it, 1 year and a half of 20 minutes consultations. So it's not, you're never going to get a perfect resource now. PASS has obviously changed its website, for example. So you can watch those videos and you can see those sort of clinical consultations, but there is actually no sort of real placement for getting, real life practice on the medical take. So what I would advise is that if you're on the, if you've got a good reg or etc., and there's a case, just try and ask them to see, okay, look, can you just do, I don't know, watch me do something for 15 minutes or something like that, and sort of that sort of aspect. It's really tricky in hospital to do a clinical consultation, but it is possible, I think. I hope that sort of helps. So an A to MRC PACES, but all of these resources that have been out there are slightly outdated because they're not there for the 20 minutes. There's obviously PASS test, which everyone uses, but there's really no surrogate apart from real life practice, unfortunately. How long do you roughly think should be used to prepare for PACES? So that's a tricky question. Everyone's very different. So I would say you need an entire sort of run at it. Okay, so what does that mean? So I think you need, so let's say you're sitting, let's say you sat in this window. So you need to just started slowly in the summer, and then when it hits the window, so you've applied for the exam, you just go hard at it, and you go. Obviously, I'm going to advertise the course, but I think you should be going on a course as well to sort of consolidate, because there's things that you would only see on the course. Okay, there's conditions you will never see, as even if you did a medical take every single day, you won't see it come into hospital. So you do need to go on a course. I hope that sort of helps. So basically, I think it's sort of 4 or 5 months worth, where the first 2 months are probably, once a week, twice a week, and then you start slowly increasing, and at the end you have to go almost 3 or 4 times a week, as much as work allows, and then by the last week, so if anyone's got exams coming up soon, my advice is the last week you try and not do too many examinations. Okay, there's going to be people in the group, and as you can see in the 23rd, and then there's going to be someone who's going to present how they pass PACES. But my advice would be the last week you would try and stop examining too many patients, because you just need to try and consolidate the knowledge that you have, practice your presentations, and the exam hopefully will take care of itself. Any other questions at all? You can put it on the Q&A, you can put it in the chat, and I think Shoaib will make the recording available for those who joined a bit late. But thank you so much for all of you who did join on a Thursday evening. If there are any other questions, you can put it on in the WhatsApp group as well.